Alex. I'm going to introducing you in English.
Yeah.
Okay. Muy buenos días a todos. Sean bienvenidos. A nombre de la Walter y Dandy Mexican Club, extiendo un cordial saludo y una cordial bienvenida a todos los participantes que nos acompañan el día de hoy. Es para mí un placer presentarles al doctor Ahmed Nabil el Grafni, quien estará a cargo de esta excelente sesión magistral sobre los avances en el tratamiento del glioblastoma. Él es un miembro del equipo clínico de neurocirugía del Hospital St. George en Londres, Reino Unido. Tiene una maestría en cirugía que la obtuvo en Monsoura, Egipto, y una membresía intercolegial del Real Colegio de Cirujanos en Inglaterra. Es un honor tenerlo en esta conferencia, doctor, así como a todos los participantes. Y bueno, esperemos que disfruten esta magnífica sesión magistral. Estoy seguro que todos vamos a aprender muchísimo del vasto conocimiento y experiencia del doctor Ahmed. Alex.
Good morning, everyone. The Walter E. Dandy Mexico extend a cordial welcome to all the participants. It's a pleasure to introduce you Dr. Ahmed Nabil El Gamri to this lecture about advances in management of glioblastoma. He's a neurosurgery clinical fellow at St. George Hospital in London, UK, Masters in Surgery in Monsoura, Egypt, and intercollegiate membership of the Royal College of Surgeons in England. It's an honor to have you in this lecture, Doctor, as well as all the participants. The forum is all yours.
Okay. Thank you, Doctor, for your kind invitation. I will share my screen now.
Yeah, sure.
Yeah. 1 second. Yeah, today we'll talk about the update on the management of glioblastoma.
Doctor, we can see your screen yet.
Okay, 1 second. Oh, yes, sure. Yeah, now?
Yes?
Yes.
It's all right.
Yeah. So we'll talk today about the update on the management of glioblastoma, and I have no disclosure. We'll talk briefly about epidemiology, the WHO classification, the 2016 and the most recent one, genetics, and the types of glioblastoma, clinical presentation, histopathology, radiological diagnosis, and the management and the new treatment options. So regarding glioblastoma epidemiology, it is the most common malignant intracranial neoplasm. It constitutes 15% of all intracranial neoplasms and about 50% of all astrocytoma. And the incidence varies from between countries. It's 3.1 in the United States, 2.05 per 100,000 people in the UK. The age is 65 to 75 years, with more of some male parietal more than female. Majority of glioblastoma are sporadic, but sometimes come in inherited syndromes like neurofibromatosis 1 and Lifromini syndrome. So classification 2016 have changed from the previous one in 2007, and it's based on the molecular genetics in general, and for glioblastoma was related on mainly on the IDH, which is just have 3 types: IDH wild type, IDH mutant, if there is a mutation of IDH enzyme, it will be called IDH mutant. If there is no mutation, it will be a wild type. And there are three subcategories under the wild type. These are the giant cell glioblastoma, gliosarcoma, and epithelioid glioblastoma. If there is no characteristic for these two groups, it will be NOS or no characteristic specified. So this slide shows the briefly how the pathogenesis of glioblastoma. We can see here we have two types: primary glioblastoma and secondary glioblastoma. The primary is the most common one, and it just genetic transposition or transformation directly from the progenitor cells directly to glioblastoma in about 3 to 6 months, with EGFR amplification, which is endothelial growth factor receptor, TB35 mutation, and P10 mutation. All of these are genetic genes on certain genes numbers, and this is a gene 10P and 10Q. The other type is the secondary, which is rare, and it just the progenitor cell can transform to more benign forms. The diffuse astrocytoma is considered grade 2, and then anaplastic astrocytoma, which is grade 3, higher grade of malignancy, and then at the end transform to glioblastoma. So this is the main differences between the primary and the secondary is the mutant type. So this is like originate de novo, and in 90% of cases, it's only 10%. The median length of clinical history about 4 to 6 months, as we said, and this is developed over 15 months. The overall survival is better for the secondary type. This is more malignant. Both of them are more supratentorial, but the difference in mutation is TERT and TB53 is more common secondary, while the TERT is more common in primary. These are summary of some of the genetic mutations in GBM and the loss of heterogeneity, and as we said, and this is associated with poor prognosis or poor survival. B53 deletion, EGFR, and vascular endothelial growth factor, endothelial growth factor receptor, all of them are upregulated in glioblastoma. The new classification, which is proposed to be released soon, so the glioblastoma will always be IDH wild type. The mutant type will not be considered a glioblastoma. In addition, the diffuse astrocytoma, which was considered always grade 2, so it will be, and it was 2 types as well, the IDH wild type and mutant. It will be always as a mutant type, and it will be graded from 2 to 4 according to histology and the discovery of this new novel genetic parameter, which is the CKNB KN2A/B homogeneous deletion. So if this is found deleted as a positive finding, it will indicate this is grade 4. Regarding the clinical presentation, of course, it depends on the location of the tumor, but general symptoms are the symptoms of high intracranial pressure, like headache, vomiting, blurring of vision, double vision, or diplopia. Sometimes present with seizures, and focal neurological deficit, like if it is in the motor area, it will cause contralateral hemiparesis or speech areas. According to where is it, it will cause dysphasia or aphasia. The histopathology, it's pleomorphic when you see it under the microscope, you will find the pleomorphic astrocytes with marked atipia and mitotic figures, which are similar to grade 3, but the characteristic for glioblastoma or the grade 4 is always the necrosis. If you find necrosis and microvascular proliferation, they are the diagnostic features for glioblastoma. And of course, there are a lot of variations and different types of cells, like giant cell, gliosarcoma, epithelioid, genostocytic, granular, and small cell. There's only some variation in the cell type and shape. Regarding the radiological investigation, CT brain, as we see here, this is a contrast CT scan for the brain showing a lesion in the right frontal area. There is two areas here: central area of necrosis, which appear hypodense because it is darker than the brain, and there is some contrast, ring enhancing contrast here. This area is a solid. This is the solid cells, which is formed of cells. These are the cellular part, but this is necrotic area. Sometimes there are calcification and like irregular enhancement, but many times it's like appear as a ring enhancing lesion. For the MRI, there's different series. As you see, this is T1. T1 I didn't because if you see here the CSF and the sulci is black. If we see the ventricle, there's no image for the ventricle here. You cannot see it, but the CSF will be black in T1. So the tumor is iso-intense or hypo-intense. I mean, hypo-intense means darker than the intensity of the brain color, like this gray color, and this is black, so it is towards the black, and iso-intense is very similar. As you see, these areas are very similar to the brain. The T2 or the flare is different. The CSF is white in the ventricles, and you can see this lesion here. It is you see this brain matter, and this lesion is hyper intense. Okay, because it is like not darker than the brain, and you see this amount of surrounding edema, which you can see around the tumor, and T2 is very useful in detecting the mass effect and the surrounding edema, and of course to see the characteristic of the lesion as well. And you can see also the void signals, which are the blood vessels inside the tumor or around it on the wall, so to take precautions during surgery. The T1 with contrast, so you can see the typical, as we said before, the central area is necrotic, so it doesn't take contrast. The surrounding and ring enhancing lesion is enhancing on the center, because these are the active part or the cellular or the solid part of the lesion, and this characteristic. The thing is, it is differentiated from abscess by DWI, which shows restricted diffusion, while glioblastoma doesn't have restricted diffusion from DWI or diffusion weighted imaging. We come to the MRI perfusion. This is the same picture, like the same MRI for this lesion. So it shows us the cerebral blood volume and different areas of the brain. So this is a normal areas. These are where the blood vessels are. So you can see the vascularity, and you can see the brain. There's no vascularity here, but you can see more red color here, or a vascularity means a rich blood supply to this tumor. So it is higher blood volume compared to the normal brain. The other modality is a spectroscopy. And when you see here, this is a tumor. So they just take a small area of the tumor, usually take the solid part. So if we can see the previous scans, they will just detect the amount of these substances in this area of the tumor. Of course, it will be in the solid tumor, not in the necrosis. And you can see here the choline high, the lactate is high, but the lipid also is high. The AA is decreased, and this is characteristic for many tumors, but more for glioblastoma. For the DWI, which we just mentioned now, the diffusion weighted imaging and ADC, for this necrotic area, you see that this is a lesion on the right, osteoparietal and occipital lesion, showing this central area of necrosis and a solid part surrounding it. So this area of necrosis shows no restricted diffusions. It means facilitated diffusion, and the idea or the principle for DWI is it detects the movement of water at different parts of the brain. So if there is a cellular part, it has a restricted diffusion because it prevents the water movement through it. So it appears like white in the DWI as here, but for the necrosis, it's fluid and it allows the diffusion of water through it. So it appears as dark here. And the contrast, the ADC is countercurrent image, which show the reverse. So if this is light or bright here, this is dark here, this means it is cellular part, and the necrotic area, so showing facilitated diffusion because it's necrotic and more fluid, and it will appear as, in contrast to here, it will be the opposite. The PET it just demonstrate accumulation of FDG, which is depend on the glucose metabolism, and we know already like the glucose metabolism is high in tumor cells, so it detects this accumulation of fluorescence substance like FDG, which is typically greater than or similar to metabolism in gray matter. So we see in this area, this MRI was contrast showing a lesion here in the left frontal lobe with just this here, some different positives enhancing lesion, but you can see here the uptake or the accumulation of the substance on the PET scan. So it indicates it's an active tumor. Regarding the management, start with some medical treatment. Anticonvulsants usually start with monotherapy, like levetiracetam. Some use still phenytoin, but usually use levetiracetam, and it's indicated when there is a history of seizures. And you also always remember there is a potential interaction between dexamethasone and phenytoin. The non-enzyme inducers preferred for patients on chemotherapy, so it doesn't increase its effect in the usual doses. For steroid, this is a main drug used pre and post-operatively, especially with lesions in lesions with a high or have a significant edema around the tumor, and patient mainly have high pressure, high intracranial pressure symptoms. It usually takes as an oral of 8 to 16 milligrams daily, and it works through to reduce the mass effect of the edema around the tumor. And we know that when we use it for a long time, it has to be tapered to avoid this side effect, and it has to be under prophylaxis against stress ulcer or peptic ulcer. And from side effect, of course, increased appetite, cushingoid appearance, weight gain, proximal myopathy, fungal infection, gastric ulcer, and glucose intolerance. And if the patient have diabetes or hypertension, it will be difficult to control, so it needs monitoring. We come to the surgery. So there's two options. If the lesion is deep or in eloquent area, small lesion, or suspected of something other type of tumor like lymphoma, If you are suspecting lymphoma, we go to do biopsy, medical treatment, or if there is suspected metastasis with a non-primary or abnormal feature of a tumor, which we are not sure about its nature. So we go for biopsy, and biopsy has either freehand using the ultrasound, using the biopsy needle, or image guided, and the image guided either frame based like the Excel frame or frameless as in neuronavigation, as we will see. So the frame based is this. This is a patient. We just fix a frame which is to the head of the patient by screws. We just let him to do. There is in this metal bars, there is some indicators, and we send the patient to do MRI, and the MRI of the patient shows a picture showing these signals. So when we see the MRI, we can just relate to the lesion or the tumor to this identification points, and go back to theater, and after adjustment and measurement of a lesion here compared to this metal which has the indicator, we just have a precise measurement of how much the depth which the needle should go inside, and to just know the target exactly, and can be do the biopsy through this needle. The other more advanced is the image guided, or see after. It is very similar to the resection, but for the biopsy, it is a very similar. Just the patient MRI is uploaded to this machine, like the neural navigation system, and through this this is called the stereotactic wand. It is just a register on the head of the patient where the tumor is, and you can see on the screen the tumor exactly where it is, and you can detect the craniotomy to localize where the tumor is, and to localize the craniotomy and its size. And after detection of the lesion, you just introduce the needle to the target which you decided or registered before, and you just do the biopsy. This is where the screen, you can see on the screen here the MRI of the patient here. This is T1 with contrast. You can see tumor here in the right frontotemporal area, and there's 2 points. One is the target here, if you can see it, and the entry point. You just this is in front of the coronal suture, which is classic entry point. So it just give you help you to draw the track you are going through, and you go through the target. After you register this, the register will transfer to the patient, and then from this entry, when you go through with the needle through this way, you can see it advancing through the brain to the target, and you take the biopsy. You can see it on the screen. The surgery, the most recommended surgery for the glioblastoma is a maximum safe tumor resection, but it has to be maximum and safe. So it is to just achieve this, there is some techniques to increase the amount of tumor resection, like the image-guided resection, which seen and I will show you now, and the fluorescence-guided tumor resection. This is the image-guided tumor resection. This is in our operative theater. This is a table, and this is a patient. This is the neural navigation system, which have a monitor, and there is a camera. Through this wand, which I showed you before, which have these sensors, we draw on the patient head, and it appear here on the screen, as I showed you before, where the tumor is. So you can just go from here to there to the, just you can see the tumor on the screen, and then you localize where the craniotomy is and how much the size of the craniotomy will be. This is what is on the screen. This is the tumor here. This is a registration, and this is a tumor showing the relation to the corticospinal tract from the motor area. And this is in the left parietal region, so you can localize it very accurately and the relation to the important structures. And then from outside on the skull, you can localize where the craniotomy will be, because you can see exactly where the tumor is. Here, there is some, like, this shows a 3D model for the tumor and related blood vessel. This is a tumor in the posterior fossa, which is infracentorial, and you can see here the circle of Willis, the carotid artery bifurcation to middle cerebral artery, anterior cerebral artery, which is going to frontal, to posterior communicating to posterior cerebral, the basilar artery and its two divisions of posterior cerebral. This is a two vertebral, and you can see the posterior cerebral artery and its relation to the tumor and its branches, so you can take precaution during surgery. Here also, as I said to you before, to just detailed visualization for the tumor in relation to the anatomical structures. You can see this, the same tumor before. It's in the posterior fossa, and when you register it with this with the stereotactic wand, as I mentioned to you, showed you the relation to the ventricle. This is a lateral ventricle, and this is the fronto-occipital fasciculus, the white fibers, white matter fibers, which are transmitting information from different loops to the other, or different brain to the areas to the other, and this is the optic chiasma and optic tract. So it's very, very useful to just have to know the relation to the different anatomical structure before doing surgery. The second thing is a fluorescence guided resection. The aminolevulinic, the 5-aminolevulinic acid is absorbed by different variety of body cells, but especially with the brain tumors, and it's converted to a substance called protoporphyrin 9. It accumulates in the glioblastoma cells, and it helps to maximum safe tumor resection. So the patient ingest it or take it orally in the morning of the operation, about 4 hours before surgery, and it appears pink or orange when you see on the blue light of the surgical microscope, as I will show you. Where the result for using the fluorescence was elaborated by Stumar et al. In 2006, showing more complete tumor resection in 56% of cases, which was used in, compared to 36% of patients who had like the white light on the microscope without using the ALA, and they show also there is improvement in the progression-free survival. Means that the certain period of time where there is no progression of tumor over 6 months show improvement with the use of white ALA. This is a picture from theater. So this is a normal, you see this is a brain, and you can see this is the picture using the white light, the normal light of the surgical microscope. You can see here this is the brain, and this is the abnormality here. This is a lesion or a tumor. And before starting, you just use the blue light here. It's only transformed, just adjusted to the blue light on the microscope, so it appears here a pink area. These are the tumor cells which uptake the 5-ALA, and you can see how the pink color it's it forms. So we just can take this tumor or excise it more accurately because you can see the borders more clearly. So you can just go around to just make sure you are within the tumor. You don't go to the normal tissue which appear blue, and at the same time you achieve the maximum resection that you can achieve. And here another picture. This is intraoperative picture. So you can see here, this is normal brain, and this is a tumor, and this is a tumor margin, the area between the brain, the tumor and the brain. So when you see here, this is the same image. The blue light is a normal brain. The tumor, as we said, is a pink color, and between them you can see the pink color is more faint. So when we do the surgery, we just go this area, just take out this area, but we leave the normal brain. So it helps us for further resection of some areas of the tumor you cannot see with the normal white light of the microscope. Okay, so what are the other techniques that we use to just avoid neurological injury? We have the functional MRI and the tractography. We have the awake craniotomy and cortical mapping. This is to just try to avoid, at the same time, we want to do a maximum resection of the tumor, but at the same time, we want to avoid a neurological injury around the tumor. So functional MRI and the tractography. The principle of functional MRI, when the patient doing a task like finger tapping, this activates the motor area in the brain, and for this activity to happen, it increases the oxygen supply and the blood supply to this area of the brain, to the motor cortex, and this increase in the oxygen and blood volume, it can be detected by the functional MRI as a signal there. So it can help to detect the functional area of the motor and speech areas, which are usually near or surrounding the tumor. The tractography more for detection of the white fiber tracts like the corticospinal tract and its relation to the tumor. And we see, we know this, this is the motor area, this is central sulcus, and this is a supplementary motor cortex. We see here the distribution for the motor, for the body on the motor area. So this is medial and this is lateral. So in the medial part, the motor area controls the movement of our leg, trunk, and thorax and abdomen, and then to the hand, and then the face. So this area, this is more medial, so this will be controlling the leg, and this area will be the hand, and this will be the face, because this is all the motor strip or the motor area. It controls the movement of different parts of the body, and this is its distribution or representation. For the functional MRI, we can just localize, as we see here, this is a coronal section, and this is the motor cortex, as we see here. So this is a leg area, which appear in red. The green area is the hand area, and the blue one is the face or the tongue. So we can just localize these areas controlling our motor movement. So its application in tumor surgery is just when we do a functional MRI, there is a lesion here in the right frontoparietal area, and you see here this is the central sulcus. So you cannot see it here because it is obscured by the tumor, and we don't know where is the motor or sensory area. So we do the functional MRI to detect this yellow and red areas are the motor cortex, which is, this is a normal here, but it is displaced anteriorly by the tumor. So it helps us to detect its relation to the tumor before surgery. So, for example, if we approach the tumor, we will go from behind, not from the front, and when we just take more precaution when we do the surgery or the removal for the tumor at the anterior border. And we can see here the tractography. So this tumor is a 3D rendering of tractography. You can see this tumor mainly in the frontoparietal area, and you can see in front, yeah, you can see the corticospinal tract extending from the motor area to the brainstem. So you can see the relation to the tumor. So you know now the anterior border and the medial border of the tumor is gonna be related to the corticospinal tract. So you take more precaution when you reach this area. And this is a coronal section showing the corticospinal tract in relation to the tumor. The awake craniotomy and brain mapping, this is the gold standard to detect the functional brain areas, and it depends on its intraoperative technique. We just open the dura, and this is the brain. This would be some tumor in some area here. When you stimulate, this is the motor cortex. When you stimulate the motor cortex, it will result in the patient twitches in the upper limb or lower limb according to the area. So, and if you stimulate the speech area, it will produce speech arrest. So it can be used while the patient is awake. That's why it's called awake craniotomy. The patient undergo serial testing of movement, finger tapping, and moving his arms and legs. And if we test for the speech, we ask some questions and he reply or answer it. But if he cannot talk, this means that we are getting in close relation to the speech area while we are doing the surgery. So we are taking more precautions. We are keep away from these functional areas. This is an image from intraoperative. So when we open the dura, these two electrodes, and it has numbers here, 1, 2, 3, but it doesn't appear in this image. These two electrodes put on motor area, and it's used for intraoperative monitoring through the graph of the line. So when you do, for example, a tumor surgery, as we see here, this is a tumor, this is MRI image which was uploaded before, and showing a functional MRI, the motor areas here and the language areas on red. The other side showing the tumor, and this is the areas where the motor activation happened. So we know where is it exactly, and we put this electrode on the motor area, and while we are doing surgery, we just take more precaution not to or to avoid injury to these areas. Following surgery, the most standard care of treatment is a STOP protocol. Mr. Stopp had published it in 2005, and it consists of radiotherapy and concomitant physiotherapy. So the radiotherapy is total of 60 gray with concomitant chemotherapy for 7 days per week, and after radiotherapy finish, just continue on for 6 cycles of chemotherapy. And this is a standard method of treatment for glioblastoma. So it is maximal tumor resection followed by STOP protocol, which is radiotherapy with concomitant chemotherapy, followed by adjuvant chemotherapy after that. And Mr. Stopp have found just the 2-year survival is have significantly higher than using his protocol, much higher than compared to radiotherapy alone. Well, the new treatments for glioblastoma, this is the targeted therapy. There are some few pathways through which the glioblastoma can form, or these are the three ways of pathogenesis of glioblastoma, including a lot of genetic factors and receptors. So now the intention or the future direction is just target the therapy and target these receptors and substances in the pathway of the pathogenesis of the glioblastoma. And for example, anti-angiogenesis, which is anti-angiogenesis factor, the chemotherapy agent bevacizumab, is prevent the formation of a new blood vessel to just limit the blood supply to the tumor and lead to its death. Another, the immunotherapy, which is the use of therapeutic vaccines. Two types of vaccine: the dendritic cells-based vaccine and the peptide. Dendritic cell, we know it's part of the immune system, and on activation, it helps to have a T-cell immunity formation against the tumor, which just when attack it lead to tumor cell death. And the other vaccine is directed to the peptide antigen on the tumor cell surface. This is another modality of immunotherapy, which is called the CAR-TC therapy. And this T-cell provide a treatment strategy based on using patient-own selected engineered cells. So are taking the patient cells and target the tumor-associated antigens. After collection from the patient, just genetically engineered, they introduce to the patient again with the goal, the target tumor cells, and destroying it. And this is still in its infancy. It's not yet well established. It's under research. The other one is the application of an electric field, alternating electric fields of low intensity and intermediate frequency. And the studies show that it arrests the cell division and kill the tumor cells through multiple mechanisms. So all under research. And nanotechnology, the small nanoparticles, now it is the era of the nanotechnology. So because some tumor cells, there are some areas, the blood-brain barrier is impermeable to just drugs and chemotherapy agents. So discovery of nanoparticle capsules which contain this drug and introducing it systemically so it can reach the tumor site without the need to pass through the blood-brain barrier. So it is more targeting the tumor cells to kill it. Usual, all of this research around glioblastoma and future direction for more recent treatment, still because of the poor prognosis of the tumor with a median survival of fewer than 2 years. But the negative prognostic factors include if there is a more degree of necrosis, enhancement, for example, for deep tumor, the MGMT non-methylated, this enzyme just repair the DNA destruction. So if it is methylated, it just stops this its job, and it helps to be more sensitive to chemotherapy. So if it is not methylated, and it will act on repair of the DNA damage, which the chemotherapy will work through it. Of course, old age and lower pre-diagnostic functional status, there is a lot of performance status scores like the Konopsky and the ECOG. If the patient has a poor function before surgery or before diagnosis, this is one of the bad prognostic factors. These are some suggested reading for the topic, and hopefully these future directions for the treatment of glioblastoma would be helpful for the patient because it's very aggressive tumor, and we see a lot of rate of recurrence, but with advanced treatment, hopefully this will get better result. And thank you.
Thank you so much, Doctor. I wonder if the participants here in Zoom have some question for the doctor. Please be free to turn on your microphone and, well, make your question. Well, I think there's no question from the part. Yes?
Sorry for the interruption. Good morning. Thank you so much, Doctor, for the excellent talk. I have one question in relation to the treatment. What is the most accessible treatment in cost and expectations?
In cost and what, sorry? I just heard what is the most accessible. Yeah, so the most accessible, as I told you, the standard treatment is the maximal tumor resection. We can use all the techniques that I show you, the image-guided resection and the fluorescence-guided resection of the tumor with the brain mapping and awake craniotomy to just limit or to avoid the neurological injury of the functional nearby area, the functional areas nearby the tumor. Of course, this treatment is available in many countries. This would be the standard treatment, and it should be followed by the oncological treatment of radiotherapy and chemotherapy for a few weeks. And after this will end, it will be followed by chemotherapy for about 6 weeks. It can be repeated for recurrent cases, and according to the functionality and the condition of the patient, according to the age and other factors. And the main, it's not only decision of neurosurgery, it's a decision for treatment of all tumors are taken through the MDT meeting, which is multidisciplinary team meeting of neurosurgery, neurology, oncology, radiology, all decide about treatment. So it's not only decided by the neurosurgery, but as I told you, a maximum total resection followed by stop protocol is the standard. Of course, the protocol for treatment is different from country to country according to the facilities and the availability in different hospitals. But I think most surgeons and people all over the world are keen to provide this treatment to the patient. And hopefully with the new treatments, this will have more achieve more cure rates for glioblastoma. I'm not sure about the cost, to be honest, but it's available in most countries.
Thank you so much, Doctor, for your answer. And we have some questions in our Facebook.
Thank you.
For the Facebook participants. And the first is, what is the chance that the tumor will come back after surgery?
Yeah. Yeah, so tumors in the brain with, as you see, there's a lot of techniques to try to achieve the maximum safe tumor resection, but because of its infiltration in the brain, even with the resection, will be the border around the tumor, which is infiltrated by tumor cells, which cannot be expected. So the main thing for surgery is maximum safe tumor resection, but it is gross total resection brain beyond this point. And it depends on the availability really of these techniques that I mentioned, the fluorescence guidance and the image guidance technique, because when we use these techniques, it helps us to just have a good percentage of tumor and decrease the recurrence, or at least to delay the recurrence, especially when we start the treatment of radiotherapy and chemotherapy. The other thing is, because of these tumors of the brain, the resection of the tumor always depend on the location. Where is it exactly? If the tumor is deep or near the thalamus, or it's infiltrating the motor area, or deep, which is not accessible. So as I said before, we do a biopsy, but it is difficult to just remove it completely. So sometimes there will be a residual, which after which there will be a recurrence or regrowth of the tumor again. But as you see, that is recurrence rate is high, and some people I saw have recurrent tumor 3 or 4 times. But as I said, the treatment depends on the patient condition and the multidisciplinary team opinion.
Thank you so much, doctor. We have another question. What long-term side effects or late effects are possible based on the treatment of the patient received?
Can you repeat again, sorry?
Sorry, can you repeat me, please?
He said if you can repeat.
Yeah, can you repeat again? Sorry.
Okay. What long-term side effects or late effects are possible based on the treatment that the patient received?
Yeah, the long-term effect of the treatment, you mean? Is that right?
Yes, doctor.
Yeah, so the tumor itself or surgery sometimes lead to neurological deficit in the form of weakness, contralateral hemiparesis if it is in the motor area, or speech problems if it is in the speech area, or if it causes very high intracranial pressure with a mass effect from the surrounding edema, it leads to disturbed conscious level and coma, of course. The radiotherapy is known to have cognitive effects, and this is affect the cognition of the patient, thinking, and the mental functions, especially after the treatment. The chemotherapy depends on what is the substance, but mainly the GIT, affect the GIT symptoms, thrombocytopenia, hair loss, and myelosuppression, or suppression of the bone marrow. It depends on what is the use of the chemotherapy agent, which is mostly the temozolomide and glioblastoma, but some other substances used in the recurrence and in addition to the temozolomide. So the long term is a neurological deficit related to the tumor itself due to the compression or the infiltration of the brain areas, and the cognitive function affection mainly due to the radiotherapy, and of course some other general effects like weight loss, anorexia, and general fatigue and hypermetabolic state for the body.
Thank you so much, Doctor. We have another question from Ignacio Tain. He said, how does death from glioblastoma multiforme occur?
How does
death from glioblastoma multiforme occur? I can paste in the chat if you want to read the question. Right, it's now in the chat.
Yeah. As I said, the glioblastoma is one of the most aggressive tumor, and as we see in the presentation, the median overall survival is about varies from 6 months to 1 year, especially if it is wild type, which is the most common type. So this is only the survival rate. It increases up to like 1.5 years or up to 2 years with treatment for the other the IDH mutant type, but the aggressive one, the linear survival is still up to 1 year, even with treatment, maybe 12 to 15 months.
Thank you, doctor. We have another question. Are there any other diseases or brain tumors that might show elevated lactate and choline levels that could confound the diagnosis of glioblastoma?
Yeah, choline and lactate level are high in other tumors, like other types of glioma, the astrocytoma, for example. But the combination of NAA is very low, and the reasons choline is high because it is present in tumor cell or a cell destruction marker. So with the glioblastoma, there is more cell destruction, so the choline is high, and it's apparently high with other tumors. But this ratio of a high choline with low NAA, which is normal neuronal. The NAA is normal neuronal cell marker, so it is high if there is normal cells. That's why it is very low in tumor cells, because it's not a normal cell. So this ratio help us to diagnose with other findings. Of course, it's not only the only finding for spectroscopy, because other lesions, some are similar to glioblastoma.
Okay, thank you. And we have one last question. This is I think is a pretty difficult question. It says, it's from a follower in our social media. Regarding the CRISPR-Cas system as a possible treatment for glioblastoma, do you think that at some point it could be used as a gold treatment, since it has been seen in research that it does not cause side effects, and it has even been mentioned that cells will never react again?
Yeah, can you tell me what is the treatment, the modality? What is
the CRISPR-Cas system? I think it's a molecular system.
You can type it for me, because
yes, this is in the chat.
Yeah, there are some countries use the CRISPR-Cas system for treatment of glioblastoma as other new modalities. It's not in, I think maybe only one center in the UK doing research for it, but the other, I think the other centers are using a lot of other modalities, like the CAR T cell and the immunotherapy, all of them are in its infancy, are all under research. There are other chemotherapy like the carnosine, the wafers, which are locally after brain tumor excision, used after surgery as well, but we don't use it here in the UK because of its adverse effects. So there's a lot of modalities of treatment that are under research now. Hopefully this will be promising. So regarding any other treatment, all of them are under research now. Cannot comment on the result or anything except after a good, like randomized control studies to show the result, and if there is a recommendation, maybe the treatment of glioblastoma will change maybe in a few years or something. But we still have a lot of research regarding glioblastoma and glioma in general, but especially with the high-grade tumors.
Okay, thank you so much, Doctor. Well, thank you so much for all the participants here in Zoom and in our social media. And thank you also to you, Doctor, for your great presentation and for your time and to share your knowledge with us. I know everybody cuts a bite of your knowledge today.
Yeah, thank you so much for your invitation and your time again. And all the best. I hope you enjoyed it.
Thank you so much, Doctor. We're going to stop the transmission, but please don't leave the meeting. Yeah.
Ya estamos fuera en Facebook.
Sí, pero creo que en YouTube todavía no estamos fuera.